Thank you all for being here. We're very happy to have you and excited to present the latest changes in Medicaid for 2022. My name is Nicole Christensen. I'm a board certified patient advocate and president of Care Answered, where we get health care done. We do that by advocating and coordinating care, navigating people through the healthcare system so that they can access their best care and give their loved ones peace of mind. I'm also the author of the book, From Crisis to Come. So I'm going to get started right away on these changes. We're going to start with kind of what it is now and what it is proposed to look like in the very near future as far as Medicaid is concerned, and what steps that we can take to better ourselves, our clients, our loved ones, our family members. So I want to start with Anne, who is a great friend and a wonderful and excellent attorney. She's an elder law attorney. She is with the Dello Iacono Law Group, and she is a mother as well of 4 fabulous children. And I'm so excited to have her here today as she is part of the Care Answered family, meaning they're partners, we work together, and I only like to invite the best here, and this is no exception. So Anne, will you take it away?
I know that the world of Medicaid has been very topsy-turvy. We've all been waiting to find out what's going to happen. And I just want to prepare everyone and say I don't have any earth-shattering news to present today, but I can kind of walk you through what the concepts are going to be and why they're going to be important for our clients and our family members and our neighbors and all that good stuff. So I think it's very important to point out why this is so important. Why do we have so many people here? It's very relevant because we all know long-term care is expensive. And it takes a while to get on Medicaid, right? So we have Medicare that covers very little. Some of our clients can private pay. Some have long-term care insurance, but the majority of people are looking for Medicaid at some point. Okay, so what do we have in place now? How do we get on Medicaid? Medicaid looks at your assets in one column, income in another. People love to combine those and get them confused. But you can only have $16,800 in assets plus certain exempt assets. And I know we already had a question on some of those exempt assets that I'll incorporate now. So exempt assets would include IRAs, primary residence. But the rule with the IRAs is that they must be in payout status, meaning you have to be taking out monthly distributions according to a life expectancy chart that Medicaid provides. And I think the question was, what do you do if you have a younger client? And if they're disabled, they can take out those monthly distributions. And then the other question was, well, what if you have a Roth IRA? Because those aren't taxable. So to be fair, you have 2 options with all the IRAs right now. You can liquidate any IRA and transfer the bulk of it and qualify for community Medicaid. Or Roth IRAs, you can treat them like a regular IRA, and Medicaid will let you get away with that. Did that answer your question, Don? Are we good? Okay. All right, so that's the asset piece. The income piece is that Medicaid lets you keep a whopping $934 a month plus an extra $20 if you're over 65, which is just an abundance to live off of on Long Island. So this is how I always like to present it to my clients. All right, next slide, Nicole. I say that Medicaid gives you 2 really great options. And the first is that you can take your excess income and contribute it to the cost of your care by turning it over to them, LTC or Medicaid, and then Medicaid will pay the rest of your care. And I always start with that option so that it sounds like the lesser of 2 evils, because the next option my clients don't love either, and that is that you can put your excess income into a pooled trust account. which is run by a nonprofit, and it allows you to stay home, keep use of your income, but just in a very roundabout way. You give up control because you send your bills to the pooled trust company, they pay them directly. So with these changes, next slide, people are wondering what's going to happen with the pooled trust account. And again, like I said, I don't have the inner workings of what's going on in Albany, but what we do know is that these proposed changes involve penalties for transferring assets and income. So what that means is that if you put your excess income into the pooled trust account and you don't spend it that month, that could result in a penalty. I mean, I think the $1 million question is, who's checking every month? Is that going to be a wing of DSS where someone's going to be reviewing pooled trust accounts on a monthly basis? How are they going to get notices out to say there's a penalty that month? I'm very curious to see how that's going to go. Or will it fall into the laps of the pooled trust companies? And how are they going to staff up and manage all of that? So I think, as we can see, I'm curious to see how that's going to play out. I'm not sure how well thought out that is. Okay, so that's the deal with the income. You can still use a pooled trust, but when you're planning, you know, you're going to have to sit down and talk to the client about, can you spend your excess income every month? And if not, we have to figure out what the consequences are going to be. Okay, so the other biggie is that the new changes are going to affect asset transfers. And so currently we're like in the golden era because we can just advise our clients to move assets out of their name, and then next month they're eligible for Medicaid. Starting, I don't know when, they're going to phase in a 30-month look back for home care, and you will be penalized for any of these transfers, unless it's an exempt transfer. So they're going to let you still transfer to your spouse. That's still fine. This is not replacing the 5-year look back for nursing home, as people like to think. And also tacking on to the 5-year look back for nursing home. This is a separate thing, look back period, just for community Medicaid. And so they're going to go back to October 1, 2020, or 30 months prior. Okay. Go ahead, next slide. Okay, right. So we can still transfer to a spouse. You can still transfer to a blind or disabled child. I think we can still make the argument that certain transfers were not made for purposes of qualifying for Medicaid, and therefore you should not be penalized, which is always a tricky argument to make because that just involves legal arguments, delay, going back and forth with DSS, proving your case, which we can always, we can always rely on returning the gift if possible to wipe the slate clean. All right, I have a should I do a question now or wait? Can you explain?
You can wait. Okay.
I think it's relevant now. Has
Okay.
a financial qualification component, which you discussed, but also has a need-based. Yeah, we're going to get to that. Totally. Okay. So I'm covering what's going to happen financially, and then I'm going to turn the mic over to Nicole, who's going to talk about the crazy changes with the care needs. Okay, so what's going to happen if you make a transfer during the look back? They're going to apply the same logic that they apply to nursing home care. And so for every $14,012 that you transfer, you're ineligible for 1 month. I think the real sticking point here is going to be, when does the penalty period commence? Because it's pretty black and white that you take how much you've gifted and you divide it by 14,012 and you come up with a certain number of time for during which time you're ineligible. Okay, so if you're in a nursing home, it's pretty simple. Your penalty period commences once you're in the nursing home. You have no more than $16,800 in assets, and you've made that application for Medicaid within your 3-month window. They'll start your clock. You figure out how you're going to pay during the penalty period. When it's over, Medicaid will pick up. And in the meantime, you're getting care in a facility. What's going to happen when you're at home and you're not really otherwise eligible until you've had this functional assessment first? So the penalty period for home care is going to start once you're getting services at home, otherwise eligible, and you've got an approved application along with functional assessment showing you require home care. So I'm curious to see how that's going to play out logistically with the delays that we're expecting, right? How long is this going to take to get your functional assessment approval, your Medicaid approval? And are you going to wait out an extra 6 months before your penalty period commences? It's going to be a little difficult to plan with. But again, we don't have details on how this is going to play out logistically. We just know the concepts and we can see some of the problem areas. All right, go ahead, Nicole. Oh, so I do have some good news. It's not all doom and gloom. Spousal refusal has not been eliminated. They're always trying. It's on the chopping block, I feel like, quite often. But you can still make transfers to a spouse, and they can sign the spousal refusal, saying, listen, I would love to contribute all of the income and assets to my ill spouse, but I might need it for myself one day. So at least we still have that going. Whereas I think we used to see people were like, should I get divorced for purposes of Medicaid? Maybe people start getting married now. It'll be great. Okay, next slide. Okay, $1 million question that I'm asked on a daily basis is this happening in April? Is this happening in January? When is this happening? It was supposed to start October 1, 2020. That clearly didn't happen. There was a mad dash. I remember September 2020 was like the worst month of my life, trying to get everyone's assets out of their names. But right now what we're expecting is that it'll be, the earliest it will be is July 1st, 2022. You have to understand that, we haven't received any regulations, ADMs, or any guidance on how this is all going to play out and how this is going to run. Hopefully they know and they have a plan. They're just not sharing it with us. But there's also some legal concerns here. So the reason it keeps getting pushed off is that, New York's getting federal funding due to the public health emergency. And no, spousal refusal is still in effect for nursing home too, just to be clear. It's still good, both for home care and nursing home care. Okay, so what I was saying is we're getting this federal funding that says, listen, we'll give you this public emergency money, but you can't make any cuts to anyone's Medicaid. And so the last we heard was that the emergency funding was extended through April 14th. I don't know, maybe it'll be extended again, or not sure. But even then, are they ready, if it does end in April, to roll out quickly all of the regulations, the ADMs, and the staffing, and getting this all in place? I suspect they don't. But I think the real kicker here, the real takeaway, is that there's been a proposal in New York State to repeal asset limits for Medicaid applicants. So I don't know if you guys follow this like I do. Hopefully you're all super into Medicaid like I am. But in California, they just did this. And so New York is thinking about adopting this. And again, we're not sure on the details, but if there's no asset, limit, how are they going to view transfers? How are they going to view penalties? I'm not really sure how these two bills are going to mesh together and how this is going to play out. But I think it's something we really should all be keeping our eyes on, because that's some big stuff right there if we don't have an asset test. Okay. What else do I have? Oh, yeah. The main takeaway is, if you know anyone who's worried about it, maybe, get on the shtick and start planning earlier, because who knows what kind of look back we're going to be having. Okay, I'm going to go to some of the questions though. I saw another one in here about annuities. Can you explain how annuities in the applicant's name that were purchased and are not qualified annuities are treated? Yeah, those are treated as a non-exempt asset. Annuities are really tricky to plan with Medicaid because it's not liquid money, right? So if a client, even now, if a client doesn't have much else besides a non-qualified annuity, they have to make a decision if they need Medicaid. Do they want to liquidate, make a transfer, and get hit with all the transfer penalties, the income taxes that come along with that? Unlike a qualified annuity, which could be an IRA, and you put into payout status. Did that answer your question, Pam? Good? Okay. Okay, I didn't want to take up too much time because I feel like Nicole has like the biggest substance here. Her changes are much more in depth here.
Oh, no.
Any other questions for me?
Yes, I have a question for Ann.
Go ahead, Don. Lay it on.
My question is, just to clarify, if someone is signing up for Medicaid prior to July 1st, and they're moving assets, home base, they're moving assets before that point, there's no look back on those assets?
Got to get that application in before July 1 or whatever date. Mm-hmm.
Okay, so no look back. If money's moved in the next 2 weeks or a month or whatever, it's okay. They don't look at. They won't look at that. Okay,
correct.
Great.
Grandfathered in.
Thank you.
And that's the general thought, right? There's no definites, but that's what we're all working on, is that people would be grandfathered in.
Right. Right. There was a whole concern that, hey, all these people are going to rush and apply for Medicaid, right? And I think this is going to answer Adam's question too, which is it ever too early to apply for community Medicaid? Well, maybe if you really don't have the need, are you going to get any hours? But I have had that conversation with clients where like, maybe you'll qualify for a couple. Do you want to just get grandfathered in now, take your couple of hours, and then try to get more hours as your needs increase? And that's a whole strategy too that we've been dealing with.
And then Ann, along those same lines, does the approval of community Medicaid expire? Does it, if I say, in 3 years, I know I'm going to need something, and I apply now and I use an hour a week or whatever it is, is there any detriment to doing that for what might happen 3 years down the road?
Okay, so that's a really good question, because we were kicking around in the section the idea that perhaps with all these people trying to be grandfathered in, that Medicaid was going to go back during the recertification process every year and be like, hey, what happened here? Did you make transfers? And we couldn't do anything about it then. I think we all decided that logistically, that's not realistic. I don't think they have the ability and capability of doing that. And I'm pretty sure we got, as a matter of fact, some reassurance from the Department of Health that wasn't going to happen. We didn't have to worry too much about these recertifications capturing any prior transfers. Okay, I have another question. With these new changes, the penalty period will be calculated as we calculate the penalty period for nursing home. Correct. The calculation remains the same. You transferred 30,000 divided by 14,012 if you're on Long Island, and you come up with 2.14 months of penalty. That's not the issue. It's when will the penalty start to run? And my concern is that there's going to be a long delay before they say, okay, now your 2 months can run. And that's very hard to plan with. When you're trying to make people's money stretch and keep them in the home and make sure they have the care while you're sitting around waiting for the penalty to expire. So I think that is where we're going to have the biggest problem.
And did you see this question about the applicant's name that were purchased? Can you explain how annuities in the applicant's name that were purchased?
Covered that one.
Okay.
Yeah, that one.
I wasn't sure.
Okay, the second part of Adam's question to be addressed relates to medical eligibility issues. Totally. That's my question.
Yeah.
Mm-hmm.
Any other questions? These are great questions, everybody.
Yes, thank you for keeping me on my toes.
Ann, I have one other question. You kind of answered it in the beginning, but I might have missed it because I couldn't answer back. I was on mute. The Roth question. I've read places that a Roth, because there's no required minimum distribution, is looked upon as an asset for Medicaid. And since there's no required minimum distribution or payout, it's a pure asset. It can't be converted into income.
Crazy, right?
Yeah, so that's correct, right? That's correct, right?
No, they'll let you take your distributions and they'll treat it as an IRA.
Yeah, but there's no distributions with a Roth.
You can just put it into payout status, Don. You can just take your month, you can calculate it and have it pay out to you monthly, right?
I guess you can do that, yeah. Yeah. Okay.
I know, it's bananas, but I I agree with you.
Yeah. Unfortunately, we don't make the rules, but this is what they are at the moment. Excellent question. Thank you. Okay. So with that, and if you have questions that come in your mind, just for Anne, just throw them in there and we can get them at the end as well. So thank you very much, Anne. I am going to now be talking about the medical eligibility, right? So that means I'm going to start with what's happening now, right? So right now, if for community Medicaid, after you're financially eligible, the general rule for being medically eligible or medically approved is that you must need at least 120 days of assistance. It's actually over 120 days with ADLs, activities of daily living, to enroll into a managed long-term care. Okay. The Maximus does a conflict-free, and Maximus is just an agency. They send out a nurse, or they do it virtually often, to evaluate through a conflict-free evaluation. And they determine if you are indeed medically eligible for community Medicaid or not. Then there is the MLTC evaluation. So then one selects an MLTC, and then they do a very similar evaluation, and they let you know how many hours of care, home care, that they will provide. Now, this process is going to change as soon as May 1st of this year. Okay, so that's what's on the books. So now let's talk about what these activities of daily living are. So after May 1st, which again, it says after May 1st because the changes in how it works is purportedly going to start May 1st. And then these changes of activities of daily living is going to change sometime after May 1st. So after May 1st, whenever they implement this, the activities of daily living in which they determine whether you will be approved medically for community Medicaid will be ambulating, walking, moving around, personal hygiene, like brushing your teeth, combing your hair, dressing, eating, bathing, transferring on and off the toilet and toilet use, turning and positioning in bed. So you're going to require physical maneuvering for at least 3 of these activities of daily living that I just mentioned. So physical maneuvering means you need a physical person to assist you. So I know I've said this before, but it bears repeating. So for an example is, I use a walker, and so that enables me to walk. That means I do not need physical maneuvering. However, if I use a walker, but I also need somebody to assist me in utilizing that walker, actually touch me, enable me to use it, that's physical maneuvering. Okay. So you would need to require physical maneuvering with 3 of these ADLs. However, on the good news side, and I say it because it's not in the requirements now, for those with dementia diagnosis, they need to have a minimum of supervision for 2 ADLs. So that might be, same example, I have a diagnosis of dementia, I need to use a walker, but I need help understanding how to use that walker, because maybe I forgot how to use it, or I don't know where the hand placement is, or I don't know that I should need a walker. So that would be more of supervision. So if it's two ADLs and if you have a diagnosis of dementia, and you need at least supervision, it also will cue it for approval, medical approval. So what does that mean for us? So what's changed is in those activities of daily living, it does not include incontinence when a person cannot use a toilet. So what I mean by that is I am bedbound, say, and I'm incontinent. So I don't use a toilet. So that's not what I need assistance with, but I'm incontinent. So I may need to be regularly changed. So that's not specifically included in the new rules and the new policies. It also is not specifically included. It's transfers for other than toilet use. So I certainly have clients that honestly, it's many times for modesty, but they prefer to just use the hand guards that are around the toilet that they put there, maybe with a raised toilet seat, so that they can get on and off the toilet. So in theory, if somebody said that, that means they don't need transfers on the toilet because they're using that, but they can't get up out of their couch or their chair without physical assistance. And so in these new rules, that won't be taken into account. Also, medication administration is apparently not going to be taken into account. The other things is that the instrumental activities of daily living are not going to, IADLs, are not going to be looked at as far as approval as well for medical approval, which are things like managing financing, handling transportation, shopping, preparing meals, laundry, managing medication, using telephone, housework, etc. So that's a big deal because a lot of people, getting back to Adam's question, right now may have issues with household chores, and meaning keeping things clean and preparing meals. And maybe that's it. So they would qualify maybe for a few hours, but now that won't be taken into account to be medically eligible, starting with these new changes. Okay, and how is it changing in the entire process? So that process is going to change because the assessment process is completely changing. And this is what's supposed to happen on May 1st of this year. So if that were to be true, most people that are applying right now are going to have this process, meaning they're going through the financial application right now. They may have this process, but hold on, there's more. So this is going to include the New York Independent Assessment, which starts with the community health assessment, very similar to what's done now through Maximus, similar to the conflict-free evaluation. Then after that, which again, right now would be selecting MLTC and they come and do the evaluation. Now it's a clinical assessment done by an independent doctor who potentially determines the hours. So what we mean by that is it's a doctor that has never been a part of this applicant's life, right? They're doing an independent clinical assessment. That's going to be done. It can be done by a DO, a medical doctor, a physician's assistant, a nurse practitioner. Those all fall into the category of who can provide this clinical independent assessment. So gone is the physician's order form that was generally filled out and completed by your own doctor. Then that's who helps determine the hours. Then if more than 12 hours are referred, if they're qualify potentially for more than 12 hours, then it goes to an independent panel. Then determines if it's safe for the person to remain at home, which this has big issues all around it, because it says to me that they're saying, okay, then we'll determine that you need to be in a nursing home. Well, most of my clients have no desire to be in a nursing home, and you can't force somebody to be in a nursing home. So what does that mean? Plus the fact that where are all these nursing home beds going to come from? But that's still advocacy that's going on. The other thing that we also know is these assessments are going to be done annually rather than every 6 months as they're done now. However, you can always ask, just like now, for an assessment if there's a decline in health or a hospitalization. So that doesn't change. Just their regular assessments will happen annually. So this is other changes in the Medicaid process that is part of it. As I mentioned before, MLTCs will not be part of the process in determining the number of hours of care. And your primary care physician is out of the process, prescribing the hours of care through CDPAP or personal care. And the independent doctor, who may unfortunately have no real understanding of the patient. That's where we come in. I have already an idea of how the doctor physicians will have a say. The other thing is there's a push this is already happening in dual eligibility programs, so that it's a Medicaid, Medicare combination. A lot of clients that I've had haven't utilized it because they're afraid they're going to lose their doctors that they love. So sometimes it can work very well for people, and sometimes it's not the best fit. But this is definitely the push. So PACE is a medical adult daycare where all services are on site and they're managed by the insurance provider, like the MLTC. It's all managed by that. However, there is word on the street that PACE, because due to COVID, they've been able to provide the services not on site because a lot of people weren't going up to a site. And that supposedly could be ongoing. So that means it's going to look a lot like MAP, if that's the case. So with MAP is the Medicare Advantage Plus. So that's, it's Medicare and Medicaid again together, and then it's under one insurance carrier. So again, if you have doctors that you love, you want to make sure that they carry, that they're covered or in contract with the insurance or MLTC, what we would call it before, that you're picking. So again, not bad things. Just make sure that you have the doctors. Nobody wants to change a doctor that they've been going to forever and really like and have a relationship with. The other thing is they're limiting MLTCs, meaning how many that can come on board. And I think that's already happened. I don't think we're seeing any growth of new MLTCs at this point. Now, CDPAP, Consumer Directed Personal Assistance Program. As of last year, participants don't have to be, or prospective enrollees don't have to be informed about this program. It still exists, but there's no policy saying that they have to inform you, which was the case before. So this is when many of you heard of, you have a loved one, family, friend, neighbor, somebody in your faith community provide the care for you. And they would then get paid via a financial conduit for the services through Community Medicaid. So again, this program still exists. They just may not share it with you. So if you're not working with an advocate, you may not know about it. So spread the word. Okay. So MLTC lockdown, that started already, 12/1/2020. So it used to be that you could switch your MLTC for whatever reason when you felt like it. Now you can switch MLTCs freely in the first 90 days. If it's after that 90 days, then you have to stay with that same MLTC for another 9 months, so equaling a year. And if there's a good cause, which is hard to prove, it's not as easy as it should be. But then potentially you can change your MLTC within the last 9 months. But
Nicole, can I ask a question about that?
Sure.
Thank you. Sorry to interrupt, of course.
No problem.
What education should be provided to families as to picking the appropriate and right MLTC for them? Perfect example is that there is an ALP, an assisted living program community in existence on Long Island that specifically only works with one MLTC.
Mm-hmm.
So if the individual applies for Medicaid and goes through another MLTC, it really wouldn't work at that ALP, and they might lose out on an excellent opportunity to live in a memory care community with Medicaid making some assistance on payments, which is almost unheard of in the state of New York. Mm-hmm. So is there a questionnaire? Is there some sort of investigative discovery process that should go into making the decision as to which MLTC somebody would use?
That's an excellent question. So I personally, before COVID, go with whichever is going to give you the hours that you need, right? And that changes by the day. Right. So that's a very particular circumstance, and I know exactly what you're talking about. They may be forced to, well, I guess one question is, would they then accept, because you can go from MLTC to PACE or MAP. So it might be advantageous for them to use a MAP program that does have that MLTC, because it's not going to make a hill of beans difference to them, likely, about their doctors, or change their doctors to somebody under that MLTC that's offering that care in that assisted living. But honestly, after these changes that I talked about before, I don't really know how one selects, or if people are going to have any selection process in their MLTC, because they're not that has not been made clear at all. I don't know if the state's going to be like, this one for you, because they're not part of the process. So unless somebody has a situation like that in which they say, I really want to be here and they have this MLTC, I want to use that. I don't really know what that's going to look like as far as selecting your own MLTC after these changes happen. That's a great question. Okay, so here's the big caveat. I tell you all of this, and then this is from the Department of Health. Please note, on November 8th, sections, basically everything that I just talked about, went into effect, allowing the department to permit the current assessment process to continue, which is the one that we have right now, until such time as the independent assessment and practitioner services are established at capacity. Accordingly, the department reserves the right to further pend, that means further delay, any or all the provisions listed above going into effect on May 1st, 2022, if it deems such action necessary. If such action is taken, all parties will be notified, blah, blah, blah. So basically they're saying, as I interpret it, is if we can't get all these independent assessments and practitioner services available, which we all know we're having a worker shortage, and it's certainly greatly impacting healthcare, then we can't do this until we have it. So I don't know exactly what that means, but just following trends and being in it, I don't think they're going to have this ready. I don't know where they're going to find all these practitioners that are going to provide these independent assessments, especially in these days and times. So I don't know. I don't know when it's really going to take effect, but that's the date that they're giving us. So That just means we may have a little bit more time, but again, apply for Medicaid sooner rather than later to avoid all of this. Speak to Anne or another fabulous elder law attorney so that you can plan appropriately. I thought I saw a question before about the nursing home transitional waiver and the traumatic brain injury waiver programs. They are not affected by these changes, in particular, not by as of now, by the financial changes. So as far as I understand, the waiver programs are going to be utilizing the financial eligibility that is in place now, not the one that's proposed to change with the 2.5-year look back. And, get an advocate now to best assess what care you need. I've had a lot of folks come to me before they apply just to see if they're going to qualify, because my answer today and the answer when they make these changes are going to be two different things. So it's best to know as much as possible. And again, I'll be giving updates as the information changes. Let me look into this chat. Okay. And we have one for you, I think. Don, is this what life expectancy table is used for someone who starts payout status at age 59 and a half for Medicaid purposes?
It depends on the county. New York City just uses IRS. Oh, for a younger person. You know what, Don, do you need it for practical reasons? Do you want me to just send it to you? Okay. Yeah. You got it.
And then Bonnie had a good question too. If a person is on payout with their IRA and then dies, is the balance subject to Medicaid rules?
Let's hope and pray there's a beneficiary who will inherit at death. And if so, that passes outside of the grips of Medicaid recovery. If there's no beneficiary, it can go into your estate, and Medicaid could definitely recover from those assets.
Great. Nancy asked, what is the MLTC? That's managed long-term care. That's kind of the umbrella insurance for community Medicaid. Okay. Will the primary care physician have any role in advocating for increased home hours? Well, I'm going to work hard to make sure that that's the case. And then you're talking about appeals, Linda, in which I do as well. So they can have some say in that. How the appeal process works is likely, I don't know. I'm guessing at this, but I think it's going to change a little bit because, again, the role of the MLTC is now less clear to me. Right now, it would be internal appeal, a plan appeal, and then you have appeals after that. So I don't know if that process is still going to be in play. I really don't. But they would definitely have a role there. I am going to work to make sure they have a role in the very beginning. Okay, but sadly, medical eligibility changes are already starting to take effect as Maximus and MLTCs are more rigidly applying their assessment tools to reduce care hour provisions, almost in alignment with these changes. That's a really good point. Okay, hold on. She said something else. Sorry. And referencing Adam's question of, do we encourage folks to apply to Medicaid sooner rather than later? I think we have to be careful about the medical eligibility hurdles one might have up front. I had a client denied that need for long-term care MLTC at the start of the pandemic, right after these changes were proposed, and basically applied to him. It has been long road to appeal and final decision, finally successfully getting. Yes. So those are two questions, two good points. So I don't know if Maximus is actually putting in process these changes, because I have seen in my experience, I haven't seen them put it into process as far as determining eligibility. That by policy, again, is not going to happen until after May 1st. So if one sees that that is actually happening, that's a really great appeal. Then also the reality though with Maximus is, again, because of work shortages, I believe, is that they're scheduling far out, a month or more. I've been able to get people kind of snuggled in because I keep calling and get them a cancellation, but it's really hard to get even in that month to get an appointment. So that's also causing some issues. And what the Maximus says right now is very, very important. They don't determine hours. So, but certainly currently, in my experience, MLTCs look at that Maximus assessment very, very carefully. Okay, Nancy says, if you're on Medicaid and go into a nursing home because it's too hard to find aides for home care, can you move back to home care? Are they granting the hours for home care if doctors say dementia needs 24/7 care? So those are two questions, I think, one for Anne and one for me. As far as the care is concerned, no, dementia does not say in any way, shape, or form that you automatically need 24/7. That is what will be flagged right now as safety and supervision, which this program really doesn't cover. However, I've had definitely clients that thought that that's what they need, but upon further investigation by me, there was more need that actually affected ADLs. So ADLs are really important to look at. Again, one of the good things I was saying is that in the new rules, they will actually take into account supervision for those with a diagnosis of dementia. But if that's all your issue is, which it almost never is in my experience, but if you put it forth that that's the only issue, you will definitely not get 24/7 within the community Medicaid program. But again, that's another financial issue too, Anne, regarding going to a nursing home and then coming home.
Which you can do, definitely. You can convert one way or the other. On the financial end, it's going to be definitely an issue of care and how many hours you're going to get.
Yeah. And it's not a light switch as far as I understand. It's not like, okay, we'll just switch it to that. It takes some work.
Thank you.
You're welcome. Just dementia, not traumatic or brain injuries, correct? Maria, can you tell me what you mean by that? You can take yourself off mute. Marie? Okay, I'll guess. Oh, your mic isn't working. I understand. Just dementia, not traumatic. Oh, I guess you're talking about safety and supervision. So if you have a traumatic brain injury, that would be a waiver program and not, if that's what you're talking about, wouldn't be just community Medicaid managed long-term care. For my traumatic brain injury clients, I generally go straight to that. So yeah. So if that's what they need is supervision and that's it, then they definitely would go into the waiver program and probably skip MLTC altogether. Oh, I was asking about the new changes. Would they accept the diagnosis of traumatic brain injury to need supervision? They don't, it doesn't say that specifically. No, it does not say that specifically. It only says dementia. Good question. Okay. Any other questions? Oh. Was that?
I have one, Nicole.
Okay, tell me.
This ADLC schedule that you were talking about before, that's the one that's going into effect on May 1st?
I'm sorry, which one were you?
The ADLC where you need 3 instead of instead of 2?
No, that's after. Yes, that's after May 1st.
After May 1st. Okay.
Mm-hmm. What time after May 1st is not clear. Okay. Well, I think that's all the questions. Thank you so much for being with us. And I hope you found it informative. We're very excited to put this together for you, and enjoy this weather if you can get outside. And again, happy Women's History Month. Enjoy it always. Bye, everybody.